Okay, so please have your seats, and we so that we start. And please, okay, we had our break, unintentionally, but we had our break. So have your seats, please, have your seats, and be quiet, be quiet. So, before starting our lesson today, we'll finish the tissue injury images and have the acute and chronic inflammation images selectively a bit. First of all, I'll have a psychology question. I was asked here to make the lesson from 11 to 1, all right? That's my time, 2 hours today. So, if instead of coming on time, I start the lesson at 20 to 12, and then when it's 1 o'clock, I'll keep on my lesson till 3:30, right? 3:30. If I do that, what is my problem? What is the problem of my personality? And this is very important because you'll become doctors in a few years. So, it's something that you must handle. Which disorder is this? You do not respect the others, because this is a matter of respect, not a neurosis. Start on time, finish on time, and neurotic. No, this is not neurosis at all. It's a sign of respect. Your colleagues, who is coming next, who has come before, and your students. So, what's the disorder? Who can name? Who can name the disorder? He'll guess plus 2 marks in his exams. What's this disorder? I start anytime I like. It's only me here in the universe. Not all planets go around the sun, but they go around me. Which is the disorder, please? Yes? It's narcissism. No, too many narcissists. Narcissists in medicine. No. And what's the method to face them? Leave. Leave immediately. When you contact such a person, you have to leave. But if you cannot always leave and he's your director, he's your senior colleague, then that's a problem. That's a problem. And you have to solve it. But this is not my lectures now, today's lecture thing to say. But there is a solution. All right? Anybody who needs it, just contact me and I'll tell him. For free. For free. No money. No. So beware of narcissism. So, some images, we'll pass them quickly because there are many images for us to see. And you tell me what time I have to end the lesson. It's almost 11:30. I can end the lesson in 10 minutes. I can end it. No problem for me. And I can finish the lesson in 5 hours. Any period between 10 minutes and 5 hours, you tell me, and what you tell me that I'll do. Why? Because I respect you. I respect your time. I respect your mood. That's why. So shall we finish 1, as the program was? 1 o'clock, but no break. All right, we'll have it all. Okay, so 1 o'clock, finish. If I don't finish at 1 o'clock, there will be a penalty for me. All right? So we start 11:30. So, as we, in the previous image of this, in our previous lesson, we had an image of the heart muscle hypertrophy. And this is the microscopic image of hypertrophic myocardial fibers. Look here. This is the ventricular myocardium. Remember the hypertensive patient who the left ventricle of whom was thickened? No, these are the muscle cells, you see? And he had crackles in both lungs, pedal edema, and an enlarged liver span. Think a bit. If we have crackles, rails in both lungs, that means that the left heart does not function well, so it does not send the blood to the periphery. Therefore, yes please?
What are crackles?
Crackles are sounds. You put the stethoscope and you listen to them. And what are they? Why are they noticed? Because as the left heart cannot send the blood to the periphery, where does the blood stay? Where does the blood stay? If the blood cannot leave the left ventricle, in the where? In the lungs. So if there is pulmonary circulation congestion, and since the hydrostatic pressure is increased, what happens? Plasma leaves the vessels and enters the alveoli. So that's why we have the sounds. Okay, this is consistent with left heart deficiency. Those findings here, bilateral pedal edema. Pedal edema is my feet, right? They are enlarged. And an enlarged liver. How do you understand that? An enlarged liver, of course, you have the ultrasound. But it's, if you do not have an ultrasound where you practice medicine, you'll hit here. If you hit the bowels, since there is air in these organs, there will be a different sound, because the liver is a solid structure. It does not have air in it. So, a different hitting in the bowels, a different hitting in the liver. If you have, yes, if you have this for more than 10 centimeters, instead of the other sound, of the bowel sound, that means that your liver has enlarged. So, your liver has enlarged. Your feet are both symmetrically swollen. Where's the problem? Where's the problem? Which part of the heart is responsible for this stasis of circulation? Which part?
The right.
The right, yes. So remember what we said? Let me see the previous image. First, the left ventricle was pressed, but in the end, the right ventricle was also affected and influenced. So, the microscopic findings, we see the myocyte hypertrophy. These are hyperchromatic and enlarged nuclei with an expanded cytoplasm. Of course, here we have only the abnormal. We must have some sort of normal and compare and see that these are hypertrophied. Yes, please?
Why is the swelling in the legs due to a problem in the right part of the heart?
Oh, it's very not. If the right heart does not function well, blood cannot leave the right heart to enter the pulmonary artery. So it stays at the periphery. That's why the feet are swollen, and that's why the liver is enlarged. Because the blood cannot leave the right part of the heart. Yes, please?
Generally, in hypertension, first the left side.
Yes, because that's the place which has to be stressed so that it sends the blood to the periphery where there is increased resistance due to hypertension. So the left ventricle is primarily affected, but as we discussed on our previous lesson, then there are other problems. There are problems in the lung will become congested, so the right ventricle is subsequently also stressed. And this is responsible for the right heart failure. Okay?
Yes.
Now, that was the congestive heart failure, and this, the left-sided heart failure and the right-sided heart failure, has all these symptoms that we have discussed. Look here. This is the maturation and education of T lymphocytes, which occurs in the thymus, in the mediastinum. This is a gland which is present at birth and for a few years. And what's its function? What's its function? Look, more than 97% of proliferating T lymphocytes become eliminated because they either respond to self or express T cell receptors that interact too quickly or strongly with their relevant aspects. So, what is this process? Have a look here. What do you see? There are some cells here with white cytoplasm, and there are other cells in them, but not complete cells. They are segments of nuclei. So, which is an alternative process of cellular death. Remember what we saw in our first lesson? That was necrosis, which was the main cause of necrosis. Outright ischemia. Read our previous lesson. What is another form of cellular death which is not related to acute ischemia, but to a genetically programmed model? That's what we see here. Yes, please. Apoptosis. So these are apoptotic fragments, you see? And they are phagocytosed by these cells. So we have the cellular fragmentation, that means the nucleus is broken to pieces, and then we have the macrophage. So we have these areas here with macrophage phagocytosing the apoptotic cell remnants. Okay? And what does this remind you? Which painting is famous? Impressionistic painting from the last Van Gogh Starry Night. Alright? That's not the Starry Night with the stars. It looks like it. Have a look and you'll see the similarity. The Starry Night. And so on a river, I think, there's a river, and up the river in the sky, you have the stars. Which are the stars? The macrophages are the stars. Alright? And you study some genes that block the apoptotic process, such as BCL2, and some genes that induce apoptosis, such as BAX. And the enzymes who play a principal role in the apoptotic process are the intracellular caspase. So, we have a DNA damage which stops the cell cycle for repair, and now we must see in what condition the tumor suppressor gene P53 is. If it functions well, that means that there is time to repair, all right? And if there is not some time, the cell dies. If P53 gene is mutated or absent, such as in certain cancers, it does not trigger apoptosis, so the damaged cell, the defective cell, does not enter the apoptotic pathway, and what does it do instead? It multiplies. All right? So if P53 gene works properly and the DNA damage cannot be fixed, it leads the cell to apoptosis. All right? Have a look here. Here is another apoptotic cell. You see, there is no nucleus. All the remnants of the nucleus have vanished. And you see the cytoplasm. This is a shrinkage of the cell. Now, what's this process? We have an allogenic bone marrow transplantation. What does allogenic means? Not from the own patient, not from the cells of the own patient, but from another human. So, and this transplantation, we have a desquamative skin rash. A desquamative, that means the squamous cells of the epidermis exfoliate. Okay. Which is the microscopic source? Name the process and give the mechanism by which the keratinocytes are eliminated. This is an eliminated keratinocyte. So can you distinguish in this image which are the squamous cells and which are the cells that induce their apoptosis? The cells that induce their apoptosis are lymphocytes. All right? Because if we have this sort of graft versus host disease, we must see apoptotic squamous cells and lymphocytes. Can you tell them what cells are these here? These. Have a look. They have enough cytoplasm, you see? And they are layered. Which cells are these then? We are talking about skin. Keratinocytes. All right? And how do we identify lymphocytes? They are mononuclear cells. That means the contour of the nuclei is like this, like a circle. And the cytoplasm is too little to be identified microscopically. So who can show me a lymphocyte? It will be a round nucleus, but not the recognizable cytoplasm. Who can show me? Yes, please. Here's the laser. Show me the lymphocyte.
This here. Oops.
Yes? Doesn't work? Here it is.
Here.
Oh, that's quite, it could be, but that's no, I think that's a squamous cell. It has
It's
to,
not round enough.
yes, round, but there shouldn't be any cytoplasm.
Okay.
Have a look. Where is the apoptotic cell? So the apoptotic cell, that's where. Why is it apoptotic? Because a lymphocyte went near and induced the apoptosis. That's the one, right? Show me the other one that is down. Show me another one. Give him the other. Give him the pointer. You'll show me another lymphocyte. Yes? No, here. Not this one. Okay? So these are the cells which make the keratinocytes become apoptotic, and we have the desquamative lesion of the epidermis. So this is an immune phenomenon, as you will study in our lessons of immunity. Fortunately, not with me. Yes.
How do we know that that cell you show as being apoptotic isn't just a cut which doesn't involve the...
Yes, it shrinks, it's too little, and the cytoplasm is homogenized. It becomes too pink. Yes, it's a possibility, I agree, but gaining experience will help you discriminate. So, we have the cytotoxic donor T lymphocytes, which is the donor. We said the transplant was allogenic, so there was a donor, it's not your own cells. So, and these kill host cells via the apoptotic pathway, and these are the granzymes, the caspases, which induce apoptosis, and if you withdraw some growth hormones or growth factors, this potentially induces the increased synthesis of pro-apoptotic proteins. So this is a phenomenon which is partly dominated by growth factors as well. Now let's have a look here. Here is a cigarette smoker, and we have a epithelium, a stratified epithelium of the upper respiratory tract. I want you to show me where the cells are normal, because do you know the kind of epithelium which is on the nose, the sinusoids, the bronchi up to a level? What sort of epithelium is this? What do you remember from histology? It's a stratified, yes. This is stratified. You see the layers? This is stratified. Yes, please. Columnar with cilia. Which part of the epithelium is normal? Show me, please. Which part is normal? Where you see the cilia. What do the cilia do? They take the particles and send them out, not to come down to the lung. Very good. So, we have here a change. This is a stratified epithelium, quite normal appearing, but of a different kind. What does this reaction, this adaptation reaction called? It's metaplasia. And what sort is this epithelium? It's stratified squamous. And the main factor is smoking that makes this metaplasia. This is not necessarily malignant. No, it has just changed and transformed to another form of epithelium, which is mature enough as to be recognized as a squamous epithelium, okay, but of a different kind. So, this is squamous metaplasia, and it can be reversed if smoking is stopped. Okay? Now, if we have another lesion, on this metaplastic epithelium, we could have a morphologic sign that malignancy might develop. This is different from metaplasia. This is called dysplasia and will be the object on our lesson when we talk about neoplasia. Okay? Something you want to ask me here? Yes?
Yes. Why is it squamous stratified? Isn't it more like cuboidal stratified?
Cuboidal and columnar cells are the same. Their difference is only morphological. It's the same type of epithelium. Glandular, this is glandular epithelium. It can be cuboidal, it can be columnar, it can be flattened sometimes if we have a cystic dilation of the gland, but all these are the same. So if instead of columnar we had cuboidal, that would not be a metaplasia. Squamous epithelium is something different. That's why we see that we have the epithelium has been transformed to mature squamous epithelium, so we have metaplasia. Now, have a look here. Which part of the image, I won't insist on this image because it's not for our lesson, but I want you to see something and discriminate. Which part of this is columnar epithelium, sorry, squamous. This is squamous epithelium, all right, of the cervix. And you have the pap smear, we take cells from here. So, squamous epithelium, which part is normal and where in the image you see something different? Who can tell me? Now let's see who is a bit. Come on, take the slide, take the pointer, please. Because here we have all to pay attention, right? So, what do you think is normal? That's who so it's different. Tell me the difference. Name the difference, please. Why is it different? You can tell me.
The one that I showed is
Yes, that's the abnormal. Excellent. That's the abnormal. Why is it different? What?
We show again the abnormal.
Of course. So this is the abnormal, and lower and lower. Yes. In contrast to the normal stratified epithelium. Show the normal, please.
What is the abnormality?
He'll tell you. What's the abnormality? Tell me. What color is it? What color is the abnormal one? Simple fact. What color is the abnormal? What color is it?
Darker.
Excellent. Which part of the cell stains with hematoxylin and is darkly stained? Which part? That which part? Yes, but what we see the nucleus. So, explain. The nuclei have become bigger. Have become bigger. That's why it stains dark. So, when in a cell we have a nucleocytoplasmic ratio, which the nuclei is enlarged, so the cytoplasm relatively is reduced, the cell is dark. And this is a morphologic sign that this cell may have malignant potential and become cancerous. Okay, so this is dysplasia. It hasn't become cancer yet. Why? Because it does not invade the connective tissue. So this is a pre-invasive lesion. Pre-invasive. If all cancers were diagnosed in this stage, all patients would have been cured. Why? Because there wouldn't be invasion, so there wouldn't be any chance of what? Of
Metaplasia.
metaplasia is irrelevant.
Metastasis.
Metastasis. Yes. Okay? But we'll talk in another lesson for all of these. Sorry. So, give me the pointer, please. Unless you want to keep it and show everything I asked. You want to keep the patient and show everything? Okay. So this is dysplasia, and here it's related to HPV infection. Now I'll pass the X-rays a bit quick because I'll insist on morphology, on histology. Okay, but we'll have a look at these images as well. So we have a 40-year-old homeless man with a 2-month history of fever, purulent productive cough, productive cast. That means the sputum is increased in amount. With occasional hemoptysis, there is blood. So if you see blood, for example, if you see blood in the sputum, that means that something has eroded the mucosa. That's why there is blood in the sputum. And generally speaking, which diseases damage the mucosa and give blood? For example, in the bowel, you see blood in the stool. Which?
Inflammatory ones.
Yes. One type of lesions that erode mucosas are inflammation, and the other is cancer. So how will you do? You'll have a bronchoscopy and see why the blood, what the problem is with the area that gives the blood in the sputum. And what do you do when you have an endoscopy? You take biopsies. And we look in the microscope. If we see inflammatory cells, we diagnose inflammation. So the first treatment is conservative. We give medicine. If we have malignant cells that give the blood to the sputum, there is a tumor. So the first concept is surgery. Okay? That's not always this way, but most times it is. Okay? So, what is present here in the right upper lobe? This is cavitation. All right? So, in this case, we have some sort of specific inflammation, such as secondary tuberculosis. So, in the sputum, there could be the mycobacteria, and we have a cavitation here with erosion into the airways. What is a cavitation? A cavitation is the result of a necrotic area. For example, if we have necrosis due to ischemia, and we'll see it in the brain, where liquefactive necrosis of the brain tissue, then it becomes like a cyst. So this is cavitation. It could be due to inflammation, mainly tuberculosis, but it also could be due to cancer, because cancer cells often become necrotic. Why? Because the neovascularization is not enough to keep them viable. So they become necrotic. So we see a cavitating lesion in the lung. It could be tuberculosis or it could be cancer. In this case, it was tuberculosis, and if we have the sputum sent to the microbiology for culture, we'll see that we have mycobacteria. Or we can take and have PCR against the genome of Mycobacterium, and this will give you the answer quicker, much quicker than waiting for the mycobacteria to grow in the microbiology lab. So, and the systemic symptoms of the patients, this happened in the lung. This happens in the lung. Why did the patient have soaking night sweats, weight loss? Why? Because in inflammation there are cytokines such as tumor necrosis factor, interleukin-1. They are released from activated macrophages. Because this sort of inflammation, you recall I called it specific inflammation. That means it has a particular type of cell. This is the activated macrophage. So this is a specific type of cell which is consistent with some chronic inflammatory disorders, tuberculosis, sarcoidosis, and this is the activated macrophage. Here is the necrosis. You see? Cassation necrosis. So this is a granuloma. That means inflammatory tissue forming a nodule. This is a granuloma. These are the activated epithelioid macrophages. This is a giant cell with this orientation of its nuclei, which makes it compatible with Langerhans giant cell. And here You see this part of the granuloma? Can you see nuclei here? I mean whole nuclei. We can see some parts of nuclei. But what area is this? Where you see only this color, this eosine color with no complete nuclei. This is necrosis. Is it coagulative necrosis? No. It's not due to ischemia. So this is another type of necrosis, of tissue damage, irreversible, which is called cassation necrosis. Cassation necrosis. And this leads to some sort of infectious agents. First of all, tuberculosis, but not only Mycobacterium of tuberculosis. Some fungi can also cause cassation necrosis. So, when we see cassation necrosis, we think that the lesion should be infectious, and we'll try to identify the organism. Okay? So, here in this case it was associated with Mycobacterium infection. However, the test for tuberculosis was negative because this patient was HIV positive. So, what can you tell for his immune status? If I am HIV positive, I am some sort of immunodepressed. So, if I have a test which needs a full functioning immune system, that means I cannot make the test positive despite the fact that I have tuberculosis. That's why, you see, the skin test was negative despite the fact that he had tuberculosis. Why? Because he was not immunocompetent. Okay? Yes, please.
So the reason is that he wasn't able to produce the antibodies.
Yes, so he could not, he had, being in such a state of immunosuppression due to HIV infection, when he had the Mycobacterium, he induced such a panel of cytokine expression that led the tissues to necrosis. And this is very dangerous in immunosuppressed patients who have tuberculosis. We just have, many times, we have only the necrosis, only cassation necrosis. Why? Because their immune system is not capable of making these cells, the epithelioid macrophages. So in such patients, we can have only the hypersensitivity reaction, which is cassation necrosis. Here we have to stay a bit. Yes. 70-year-old woman with a history of rheumatic mitral stenosis had an acute onset of right-sided hemiplegia. What does this mean? She cannot move her hand and her leg. 3 weeks later, she dies from complication of an aspiration pneumonia. What's an aspiration pneumonia? In people who do not have an adequate level of consciousness. For example, if somebody is drunk, if he's heavy, he drinks much alcohol, so the central system is down regulated, and he may die from aspiration pneumonia because the contents of the stomach can come up, enter the respiratory system, and he cannot wake up. Why? Because he does not have the consciousness to wake up. So, in a similar way, we have 3 features shown here. Look. So, if you have hemiplegia, this is a cerebrovascular accident or stroke. And in this case, we have an acute arrest of brain circulation. Can this be related to the mitral valve stenosis? Yes. Some part of the valve, I think we said that in the previous lesson, can become an embolus, and it leaves the heart, it leaves the left ventricle, and where does it go? Does not go down the celiac artery. It enters up the carotids and up to an artery of the brain, and it occludes the lumen, and so we have necrosis. This is ischemic necrosis, but particularly in the brain, it is not coagulative, as it would be in the heart, in the kidney. Remember we saw the infarct, the kidney infarct? That was coagulative necrosis. This is liquefractive necrosis because probably of the content of the dead brain cells. So this is another type of necrosis, you see, a softening of cerebellar hemispheric. This is liquefactive necrosis, secondary to infarction, so there is an acute ischemia, and we have some cells trying to remove the debris, and this leaves a cavity. You see the cavity? So in this case, a cyst is formed. A cyst is formed. So, and how could mitral stenosis be related to this history? That could cause thrombosis, embolization, and infarction. And if, of course, we had infectious agents, that would be a septic infarct. That means in the place of the necrosis, microorganisms would enter, and this infarct would be septic. It would have microorganisms in addition to the necrosis. This is interesting. Here is a 60-year-old man with a history of rheumatic valvular disease. So you see how much the problem in the valves infects circulation, and it can cause embolism. And he had fever and worsening headaches for 4 days. Physical examinations revealed papilledema. What's papilledema? When you look in the retina of the eye, that means the papilla is swollen. If you see that in both eyes, that means there is something increasing the pressure within the brain. All right? So if you want to examine the patient, you have to have a look at the retina in both eyes. So we have a contrast-enhanced MRI of his brain, and have a look here. So what accounts for the ring enhancement? You see here the cavity? Have a look. This is a cerebellar abscess. That means that we had a septic infarction. And what is an abscess? An abscess is a necrotic tissue due to the enzymes of inflammatory cells. So here the infarct was septic. So there were microorganisms. Some inflammatory cells went there to phagocytose the organisms, and due to the release of their enzymes, it became necrotic. So this is an abscess, and we have here, have a look at all this area, because a vital sign of inflammation is edema. Why? Because in inflammation, many substances come out of the vessels to the intracellular space, the connective tissue. So inflammation is synonymous to swelling, to edema. And you see here the edema, and what is the consequence? What is the consequence? Look here, this ventricle, brain ventricle, it's pressed, you see? So this is liquefactive necrosis, okay? And this is an abscess due to some sort of bacteria, either Staphylococcus or Streptococcus.
Professor,
Yes.
can you explain what an abscess is again?
Yes. An abscess is a cavity, a cyst, all right? However, this cyst is not empty. What does an abscess have as a content. And if it is some place you touch, you can touch, you see there is a fluid in the cyst, and it moves as you touch it. It's not solid, it's not a nodule, it's a cyst. A cyst filled with pus. Pus, all right? What is pus? Pus is the exudate of inflammation which has become necrotic due to the enzymes of phagocytes, the inflammatory cells. Neutrophils, mainly neutrophils. And pus and abscess formation is consistent with bacterial infection. Why? Because bacteria can call many neutrophils there. The neutrophils release their enzymes so as to destroy the bacterium. However, this release causes the liquefactive necrosis of the tissue. So, what does the pus contain? It contains bacteria, dead neutrophils, and liquefactive necrosis. But all this is not diffuse, it forms the content of a cyst. This cyst is called abscess. Yes, please.
So is there a difference between an abscess and an aneurysm?
Yes. Aneurysm is not directly related to inflammation. What is an aneurysm? An aneurysm is some sort of a bag that is formed in the stem of a vessel. For some reason, the wall of the vessel is not strong enough, and since the blood circulates, especially if there is some sort of obstacle in the circulation, such as atherosclerosis, that means the pressure of the blood is increased. So the wall of the vessel is weakened and forms some sort of a bag. And this is very dangerous because if the pressure is not treated, it can break. So you'll have a fatal hemorrhage. Yes?
Physiologically, how is the abscess dissolved by the body?
Yes.
How is the abscess
Yes. So if we have a formed abscess, like here, we had a formed abscess, we give medicine against the infectious agent, but unfortunately, medication, either if you give it from the mouth, per os, or if you give it through the circulation intravenously, it's going there with the blood. However, the microbes are not in the outer part of the cyst, they are in the cyst. And this area, which area? The pus does not have vessels, so the blood cannot enter the pus in the abscess. So we cannot, it is an inflammatory disorder, but we cannot have the logical treatment of inflammation, which is medication. So what is there to be, what can we do then? Think. Yes, we have a surgical procedure. Either if it is in a place where we can see it, we can cut it and let it drain for all the pus to leave and give medication, give antibiotics, of course. So that's perhaps easy if it's some place in the mouth and you see the cyst filled with pus. But if it's here in the brain, you cannot do this in the brain tissue. You have to have a surgical procedure. So that's the way abscesses are treated, surgically.
So physiologically, the body cannot cause the abscess?
No, because all the microbes and the liquefactive necrosis have made a cavity which cannot be resolved on its own. You must do something. Medication does not reach the microbes. I explained you why. So you have to have the surgical procedure. Okay? So, all right. We have pigment in cells. You see here, this is, what pigment is this? This is non-smoker, normal lung. And what is this pigment? You see, this is anthracotic pigment, probably due to pollution, to air pollution. And you see here that it can be ingested by macrophages, and it can be disposed in this septa of the lung tissue, all right? And causes of anthracotic pigment accumulation is smoking and polluted air. And here we have the histological deposition of this pigment. You see here that it is how it is stained. And of course, sometimes if we have inflammation, if we have pigment deposition, the end is fibrosis. And when we have fibrosis, traditionally thinking, it cannot resolve, because we used to say that fibrosis is not reversible. This is not so much true for today, but when I started medicine, we said that if there is a fibrotic area, it cannot come to normal again. We have a question mark today, because there are some antifibrotic agents which can, in some circumstances, reverse fibrosis. However, it's a serious lesion, this associated fibrosis, and it causes a restrictive lung disease. I won't insist on this because we'll have the lessons now next semester. That means the lung becomes fibrotic, so there are not enough alveoli, and the air in the lung is reduced. This is restrictive lung disease. And of course, if you have a right heart failure, you remember that we said that the liver becomes enlarged, and this is a chronic liver passive congestion. And this can be followed by fibrosis as a result of congestion. This is lipofuscin. This is a pigment which is much sort of some of damaging of cells, this pigment here, and is compatible with aging. And of course, in some cases, as in these patients, it can be responsible for a decrease in the whole of the whole heart. Yes, and you can see here, it's a wear and tear pigment. All right, lipofuscin. It's deposited within the myocardial fibers. And here we have a 44-year-old man with increased dyspnea, and all these signs and pulmonary edema. And have a look here. What's happened here? This is aorta, and here there is calcium deposition. This is dystrophic calcification. If a tissue is damaged, calcium can go there and stay. And this is called dystrophic calcification. And here is another case of calcium deposition, which, however, is not related to a damage of the tissue, but to a hormonal disorder. Which glands are responsible for the level of calcium in the blood? Which glands? No, not for the calcium. The parathyroid glands. So, if there is a lesion in the parathyroids and overproduces the hormone, you know the hormone? Parathormone. Then we have a constantly increased level of calcium in the blood. So this is called metastatic calcification. Yes. In cases of primary hyperparathyroidism, as it would be from a parathyroid adenoma. That means a tumor that secretes parathormone. Yes. And we have an increase in serum ionized calcium and parathyroid. Yes. That was our first And here now we'll have the other. We won't have a break, so that 1 o'clock exactly we finish. Okay, as we said, because there will be a penalty for me. Now, we'll continue with images of chronic and acute inflammation. Have a look here at this lesion. What can you say of its content? Have a look here. Look. What does it look like? This is the lesion. It's some sort of a... It's a cavity. That's right. You see there is air in it. So what can it be? We have already discussed lesions which cavitate. It could be an abscess. That's right. Well, let's see. Let's have a look at the history. So it's a young man with fever and general malaise. And we can see he makes use of drugs. And there is pus draining from this, from a subcutaneous nodule. We have some signs here from circulation. If you see that here, the jugular vein, if you see the veins here that are enlarged, which part of the heart does not work well? And you have these stasis here in the veins. It's the same as we said, the liver and the fat. It's the right heart. If you see here the jugular veins enlarged. So, this is the chest radiograph. Excellent, it was an abscess, correct. And we have neutrophil enzymes and reactive oxygen species which destroy surrounding tissues. And how did we name that? Liquefactive necrosis. Okay, so what is the cause of the abscess? Intravenous drug abuse had bacterial skin contaminants which entered the circulation and so went to which valve? So that we have a pulmonary hematogenous infection. Yes. The tricuspid valve, which is between the right atrium and the right ventricle. So, we have endocarditis, inflammation, all right? So, this justifies these findings. I don't insist because these are internal medicine findings. You'll study them in due course. So, we had septic emboli from right-sided valvular vegetations which traveled to lungs with which vessel? With the pulmonary artery. That's right, very good. And that's how the abscesses were produced. So these are cavitating lesions. Now the same patient, have a look how it is microscopically evident. And let's have a look at his blood. Have a look here. White blood cell count, 17,400. What do you think of this? What does this mean? If we measure the blood values and we see such an increase in white blood cells. What is the first we think? The first. It's infection. Why? Because if there is a damage in some part of the body, the whole reaction which begins is called inflammation. So there are some cytokines released in this area which circulate and form which is the storage of white blood cells? Where are they stored? Where are the white blood cells stored? Where are they stored? In there? Where? Which is the storage? Where do they come from and enter the circulation? Where? The bone marrow. So they reach the bone marrow and then an increased number of cells enters the circulation, and sometimes some immature cells immature cells also, you see here 8% bands. These are immature cells which were also took the message to leave the bone marrow, but this is the left-sided reaction of the marrow, and it has nothing to do with, how do we say, if immature blood cells from the muscle circulate at the peripheral blood and they are increased, which disease is possible if we have immature cells entering?
Leukemia.
Excellent. Acutely, yes. This is leukemia. Okay? No, it's not the case here. This is an inflammation which has, have a look here, 72% of neutrophils, because these are the first white cells which are motivated to leave the bone marrow and enter the circulation. So we have an increased number of white blood cells with neutrophils predominating. All right? This means acute inflammation, most possibly connected with bacterial infection. In any case of inflammation, the first cells which are motivated to go to the area of damage are neutrophils. However, a significantly increased number of neutrophils is present when the inflammatory factor is a bacterium. Okay? And there are some lymphocytes and monocytes.
Can I ask,
Yes.
can you repeat what the bands are?
The bands are immature forms of white cells which normally should stay in the bone marrow. However, in the acute phase of inflammation, where white cells, mature white cells, leave the marrow, some bands follow them. Some bands follow them. This is not leukemia. All right? Not leukemia. Yes, please.
Do they have any immunological contribution, or is it just a mistake?
The cells with the immunological contribution are the lymphocytes. All right?
The bands?
So, if we have an increased number of white blood cells, however, neutrophils do not predominate, but lymphocytes predominate instead, what do you think of? What is the cause of inflammation? If lymphocytes are the predominant population, you said it. What inflammation is that? You said it. The?
Viral.
Excellent. If it is an infectious factor, it's a virus, not a bacterium. Why? Because a bacterium would have neutrophils. This is one chance. And the other possibility, when we have an increased white blood cells with lymphocytes predominating. What's the other sort of inflammation? What would be another source of inflammation? It's one thought that it could be leukemia. Yes, it could be leukemia. We have it in mind. But there are also some inflammations which start as acute, clinically acute inflammation. However, they don't have neutrophils, as expected, because we said that the main cell which enters the field of destruction in acute inflammation is the neutrophil. However, there is a case where acute inflammation starts with lymphocytes. Which inflammations are these? Immune inflammation. That means inflammations where lymphocytes attack the cells of the body.
It's autoimmune. Autoimmune.
What?
Autoimmune.
Autoimmune, yes, autoimmune inflammation. In this case, we see no neutrophils. We have increased white blood cells, but lymphocytes predominate. What are monocytes? When they circulate in the blood, they are called monocytes. when they leave the vessels and become part of an inflammatory exudate, these are macrophages or histiocytes. So, what do you understand with this scenario? White blood cells, neutrophils, lymphocytes, monocytes, are the inflammatory cells, as long as they leave the vessels. When they are in the vessels, they are white blood cells. We count them on the examination of peripheral blood. When they leave the vessels and go to the tissues, the same cells, the white blood cells, are called inflammatory cells. So, inflammation has to do with exudate. That means substances of the blood, plasma, white blood cells, some molecules which in other circumstances could not leave the lumen of the vessels. In inflammation, they extravasate, they go to the tissues, and they form the exudate. So inflammation is inseparable with exudation. And given the fact that plasma also leaves the lumen and goes to the tissue compartment, what symptom of the inflamed tissue is justified in this way? If we have plasma leaving the lumen and gathering in the surrounding tissue, how will the surrounding tissue look like if there is plasma in the swollen, the edema? Alright? That's how it is justified in cases where we have inflammation, it's swollen. If you can see the inflammation site, it's swollen. Why? Because plasma has left the lumen of the vessels and entered the tissue compartment. So, despite the use of appropriate antibiotics, the patient dies of sepsis and pulmonary failure. Here it is lungs. Have a look at these areas. What would this, some sort of whitish tissue could be? This is, since we have bacterial infection, what areas are these? Have a look here. What exudate is this when we have bacteria as the inflammatory factor that starts the inflammation? This is pus. And if pus forms cavities, abscess. Okay? So, we talked about the left shift of immature granulocytes, and we have this exudation here. Yes, please.
Is there a name for this disease?
That's pneumonia, I think.
Okay.
Yes, but I do not insist on naming the diseases because this is part of systemic pathology. Hopefully, we'll talk about these diseases separately in the next semester when we have the respiratory system, because in pneumonia, inflammatory cells transudate, leave the vesicles of the pulmonary microcirculation and enter alveoli. This is pneumonia, all right? And if there are too many, due to the enzymes of neutrophils, the tissue becomes necrotic. Which sort of necrosis is this? That is this due to the enzymes of the neutrophils. You remember the necrosis? Liquefactive necrosis. It's the same as in the brain, but in the brain it's an ischemic necrosis that becomes liquefactive necrosis. In other tissues, liquefactive necrosis, how does a clinician define liquefactive necrosis? Pus. It's due to bacteria. Let's have a look here. We have a 40 a 5-year-old woman with a non-productive cough, fevers, night sweats, systemic symptoms, and she's lost 3 kilograms without dieting. And here we have a transbronchial biopsy specimen. So, can you please identify the parts of the lung parenchyma which are normal, and what you see that is not normal? Who can tell me and show me which is the normal lung tissue? And in this field, what is abnormal? Who can tell me? Help, please, because it's 1.5 hours and now I'm starting a bit to be tired, not very much. I'm still very young. Yeah. Today you've sat too far. I want you close. Close. Come on. Show me the alveoli. The alveoli. The normal lung parenchyma. Excellent. Excellent. What grade did you have in histology? What grade?
One. We don't know. They're not out.
Secret.
No. We still have to do the
What
lab.
are they correcting on?
We still
What are
have
they
to.
doing?
We still have to do the lab.
So you have to finish the lab and then you learn.
Yes.
I'll tell them to. You'll have an extra mark. An extra mark today because you know the alveoli. Yes, because this is not something we read in books. I've told you that in the lesson. We'll learn practical things here. Then you study the book, of course. But we must understand the practice. The practice. Yes. So I'll show you. Because this is a round lesion, you see? And what can this be here with all these nuclei? You remember we saw some cells, multinucleated cells, and they have the nuclei like, is that?
Crescents.
A ring. I'm not sure how it's called. So these are granulomas. Remember, these are Langhans, multinucleated cells. However, there is no cassation necrosis here, all right? No cassation necrosis. This does not necessarily exclude tuberculosis. That means that tuberculosis is not always accompanied by cassation necrosis. However, here it could be either infectious or non-infectious. However, we show this image to understand what is a granuloma. A granuloma is a round, a circular accumulation of inflammatory tissue. That means cells are not dispersed in the tissues. They form a round. They form a round structure, like this. So this is granulomatous inflammation, and it is related to some specific infectious agents like tuberculosis, Mycobacterium, and there is some sort of another disease that looks like tuberculosis.
What is it called?
I know it in Greek, I can't tell you. I have to look it up. I have the Google. Yes.
Stoplasma.
That's a fungus.
Leprosy.
Leprosy. All right, leprosy. It was easy. And another is sarcoidosis, immune inflammation, immune granulomas. And granulomas, these granulomas of specific inflammation are formed with epithelioid histiocytes. That means macrophages which have been taught by the immune system to make the granuloma. All right? These are epithelioid histiocytes or macrophages. But we no longer call them macrophages because at this stage they cannot phagocytose. They are exclusively secretory cells. So these are the granulomas. And they can be non-infectious. For example, dusts, unknown agents. Here we have necrosis. You see here? We have activated histiocytes. This is the immune granuloma, and here is cassation necrosis. This could be due to Mycobacterium of tuberculosis. This is a specific inflammation, but it could be due to a fungus. All right?
Professor,
Yes?
can we say again what is the cassation necrosis?
Cassation necrosis is this area here, which has no structure and it stains pink with eosin. And in Greece, this term is similar when you see macroscopic. You have a lymph node with cassation necrosis. It looks like the Greek white cheese. You know it? I'm sure you know this because I think feta. So since there is a storm outside, unfortunately, we have to wait till the storm ends. So we'll have another extra 2 hours. About 3, 4 o'clock, we may go. Oh, I have 24 minutes. You say we respect. If we don't respect the others, what are we? Okay, so since we have, now I know, I can understand that you are tired, I can understand, but be patient. There is only 25 minutes, and then we go. We all leave, not through the window. Go down the stairs. Don't leave through the window. It's the 6th floor here. No, the stairs. Slowly, slowly. I understand that you are pressed. I understand that, but don't leave from the window. You leave from the stairs. Take the stairs down. So, this is the area of cassation necrosis. Have a look at this exudate. It's in the pericardium, and this is a fibrinous exudate. This exudate is very rich in fibrin. What is fibrin? Remember, when I told you that the exudate is formed, we talked that plasma leaves the lumen, white blood cells leave the lumen and go to the tissues, and some molecules. One of them is fibrinogen. It cannot pass through the endothelium. It cannot pass because its molecular weight does not permit this to happen. However, when the endothelia, you know the endothelium? The lining of the vessels. When the endothelia are activated by the chemical mediators of inflammation, they shrink a bit. They shrink. So there are gaps, and these macromolecules can pass. And when fibrinogen passes to the tissues, it polymerizes and it forms fibrin. And in these cases, the exudate is fibrinous exudate. And what is the consequence? These fibrinous exudates are formed where we have serosal surfaces. Do you remember anatomic sites where we have serosal surfaces in the human body? Do you remember? Where we have two layers of serosa. If you don't remember, there is no problem.
What do you mean serosa?
The serosa, that means membranes. For example, you have the pericardium here. Here are two layers. One is in contact with the myocardium, and the other is that forms the cavity, the pericardium. Which other parts of the body have similar linings? With the lungs, yes. And how is this? The pleura. The pleura. And another? No, these are the meanings in the brain, the meanings. Now we are talking of layers which have a mesothelial lining. One is the pericardium, the other is the pleura, and there is another one which we must. Yes, please? Not the cervix. No, it's not an area that has this sort of lining. The peritoneum in the abdomen. And what is the significance now? if we have the exudate and it's too rich in fibrin, and this is not leased, it's not taken away, what does it form? It forms strictures. And so the heart is entrapped in the peritoneum. The bowels of the belly are entrapped in the fibrinous exudate, which forms strictures. And this is a very bad complication of inflammation. Because you see here, the fibrinous exudate, all right? And the fibrin strands, and they give this shaggy appearance to the heart. Here it is. Look, this is the fibrinous exudate. You see all these molecules here? So these are fibrin strands. And what are these? This is part of the exudate. If they were in the blood, they would be white blood cells. Now that they have come out of the vessels, they are inflammatory cells. And look at the difference. Have a look at this nucleus. Look here. And have a look at this nucleus. This one and this one. Yes, please.
So, the production of fibrin isn't the same as blood coagulation in a cut, for example.
I don't listen well.
The production of
Fibrin, yes.
is the same as when we have a cut, when we have a clot.
It's not the same. Not the same. When you have a cut, a clot is formed, that's right, and then there are some factors which make the re-epithelialization of the tissue, and this is granulation which is formed. No, this is something different. And it is preferentially formed in such areas, as I told you, pericardium, pleura, and peritoneum. Right? However, have a look at the inflammatory cells, because we must learn how to recognize them. What's the difference between this nucleus here, this one here, and this one? This is a lobulated nucleus. And this is consistent with neutrophils. Okay? This is a neutrophil. The others are mononuclear cells, which are of two kinds. Lymphocytes, mature lymphocytes, with no significant amount of cytoplasm, and macrophages, which come out of the vessels right after the neutrophils. So macrophages have a round nucleus, but they have cytoplasm. Why do they have cytoplasm? Because they phagocytose. So they have cytoplasm. Neutrophils have a lobulated nucleus. All right? But we'll see next. And if there is an increased number of neutrophils, then the inflammation is of bacterial origin. All right? Like you see here, streptococcus infection. Okay? Another very basic lesion. If we have a covering epithelium, the skin, the mouth mucosa, the esophagus mucosa, the bladder mucosa, the stomach mucosa, the bowel mucosa, and this lining is destroyed by a lesion. Have a look here. You see the necrotic area? This is pus. This is pus. It's because of neutrophils. However, since it is a covering epithelium and not a solid organ, it cannot form an abscess, it cannot form a cyst filled with pus, but we have a destruction of a covering epithelium and its replacement by pus, and however, underneath we have new vessels coming and growing, mixed inflammatory infiltrates, and some fibroblasts which are called there by the macrophages, because the macrophages do not only phagocytose, they secrete many cytokines, some of which are fibrogenic. What does this mean? They attract fibroblasts to the site of the inflammation, and they make them grow, and they deposit collagen, the fibroblasts. So when inflammation becomes chronic, we have fibrous tissue. However, this is not chronic inflammation. This is acute inflammation. You see how red the destruction is of the gastric mucosa? When, due to inflammation, we have a destruction of a covering epithelium, this is called an erosion if it is quite superficial, but if it is deep enough and underneath we have the organization of the inflammatory granulation tissue, which is, I repeat, mixed inflammatory cells, fibroblasts, all right, and collagen, and new formed vessels. So when we have a destruction of a covering epithelium and its displacement with granular inflammation tissue, this is called this is a gastric lesion of this type. It could be on the skin, it could be on the mouth, it could be on the bowel, it could be on the urinary bladder, anywhere when we have a covering epithelium, either the epidermis or the mucosa. What is this lesion called? I'm sure you know it. They talk about a gastric ulcer. These are ulcers. So what are ulcers? I repeat, ulcer is a destruction of a covering epithelium, and and we see there pus, that means an exudate of acute inflammation, and underneath we see newly formed blood vessels, because inflammation causes neovascularization. Mixed inflammatory cells. What are mixed inflammatory cells? Polymorphs, neutrophils, and mononuclear cells. Cells with lobulated nuclei, these are neutrophils, and cells with round nuclei, these are mononuclear cells. You remember how we call them when they circulate in the blood? Monocytes. When they come out, they become mononuclear cells, macrophages. Okay? However, when we see an ulcer, we should always take biopsies, not from the necrotic tissue, but from the margins of the ulcer, because there is another disease that also destroys a covering epithelium in an organ with a cavity, and it is not inflammation. What is the other disease? What is the other disease that destroys the covering epithelium? Now that we finished the lesson, have the storm. Yes, please. Cancer. That's why we take biopsies. If we see an ulcer, we take biopsies to see, is the ulcer due to inflammation or due to cancer? Yes, please. Where we get the biopsy? If you get a biopsy from here, you see necrotic tissue. You'll see pus. So it's not diagnostic. All right, you say it's pus. You'll take the biopsy here. You see the margin? This is viable tissue. Viable tissue. Here is necrotic. Don't go there and take the biopsy. Take here. We'll look it up in the microscope and see. Are there inflammatory cells? That's an inflammatory ulcer. So we can give medication to make it heal. That means to become re-epithelialized, the epithelium to form itself anew, and don't leave a scar. for example. Yes. So,
But,
this is,
can I ask,
yes please,
what's the treatment for an ulcer?
if it's benign, that means from inflammation, medication. Medication. So as to promote fibrogenesis.
They can do that by itself after the medication.
Not by itself, it's not so possible. You have to give factors which promote fibrogenesis, because why? If you leave the ulcer and this goes down the wall of the organ, it will, how to say that? It will tear it. And then, for example, in the stomach, the gastric content, where it will go? It will go to the peritoneum. And this will be a very dangerous situation because it will cause peritonitis. So you have to make the ulcer heal, not go further. If it's cancer, you'll think of surgery.
And so what happens? They cut it out. What do
You
they?
cut the organ, yes, you cut the side where the ulcer is. If it's cancer,
And then they
there's no other way, you cut it.
And then put it together.
Yes, and then you'll make the continuity, yes. So, you see here the epithelium? Here, instead of the epithelium, this is the glandular epithelium of the stomach, the gastric peaks, and you have all these hemorrhages and the inflammatory cells. How did we name this tissue? 7 minutes to go. How did we name this tissue? Remember? Inflammatory, granular tissue. This is granular tissue. I repeat, newly formed vessels by neovascularization, mixed inflammatory cells, neutrophils, mononuclear cells, and fibroblasts. All right?
This is the ulcer.
What?
What you said now is
That's on the bottom of the ulcer, underneath the pus. Underneath the necrosis, you see this tissue being organized. Don't be confused with what? With granuloma. That's something different. Remember what granuloma is? Granuloma is a round accumulation of inflammatory cells. All right? Yes, yes.
What is this again? Granular?
This is inflammatory granulation tissue, not a granuloma. Inflammatory granulation tissue. And it is formed in all sites of inflammation where the harmful factor persists. That means the ulcer is active. So this tissue is organized on its bed, on the ulcer bed. Yes. All right. What are these cells? Let's have a look. Where are they? They are not in the alveoli, they are in the interstitium. All right? So this is interstitial inflammation, and here the main cells are mononuclear. Remember what the mononuclear cells are? Macrophages, lymphocytes. All right? And these are the cells of chronic inflammation. And most significantly, some B lymphocytes which are differentiated to produce immunoglobulins. How are these differentiated B lymphocytes called? How are they called? They produce plasma cells. This is the cell of chronic inflammation. If you see an inflammatory field in the microscope and you see plasma cells, this is chronic inflammation. The cell of the acute inflammation is the neutrophil, right? We'll have another X-ray lesion. What can this be? This is the interstitial pattern we said in the connective tissue of the lung. And mononuclear cells, that means chronic inflammation. Here is another. Neutrophils and protein exudates. The chest right first, patchy infiltrations, the right lower lobe. Right lower lobe. Here, you see? How different it is? Why is it black? Because there is air. if you see the X-ray and something is black, remember the cavity, that it was black. Why was it black in the X-ray? There was air in the cavity. So this is normal lung, you see? It's black, because air is black. This is not black. So this is an exudate. Have a look at the cells. What are these cells? Round nucleus. Mononuclear cells. Can you show me a neutrophil? Who can show me a neutrophil? 4 minutes to go. Can you show me a neutrophil? Try, please. Here. What is it, the neutrophil? That has a lobulated nucleus, not a round, like the mononuclear. Can you find one? I'm not sure. Get a bit. Come down. Down. Right. Yes. We are approaching the neutrophil. Come down. Up. You passed the neutrophil. Up. There it is. You see? That one. Show the lobulation. The lobulation down. That's the neutrophil. This one. This is one nucleus, but it looks like two. Why? Because it's lobulated. Okay? Good. So, I think that we can continue our images on the next lesson. Here, I want to identify all inflammatory cells in this exudate. And that's how we finish our lesson. We'll identify all inflammatory cells, and then we'll go and get wet. No, stop. No, stop. No, that's right. So, this cell here, this one here, look. Excellent. These are neutrophils, the cell of acute inflammation. If they are too many, what is most likely to be the cause of inflammation? Bacterium. This one. Excellent. Lymphocytes. Mononuclear cells with too little cytoplasm. Now, this big one here, look, excellent. Much cytoplasm, and have a look at the nucleus. It's round. So it's a mononuclear, but it's not a lymphocyte, it's not an immune cell. This is a macrophage. Yes, this is a macrophage. And look what it has phagocytosed. You see here? Sometimes it phagocytoses other inflammatory cells. And this phenomenon is called emperipolesis. All right. Okay. So neutrophils and macrophages are present. So now that you have identified the inflammatory cells, we can study how they function. Have a look here. How do neutrophils bind to microbes? They use integrins, other receptors, and they make a complex. And there are some molecules that help the microbes, the neutrophils, to bind to microbes. These are called opsonins. What are the opsonins? IgG with an intact Fc receptor and the complement 3b fragment. All right? So, I think we should finish here, and we'll have our next lesson on Wednesday, and you'll look at the announcement. Either it will come here or perhaps in the lab. I'm not sure. I'll send an announcement. All right?
Thank you.
Okay? Bye-bye. So we know how this closes.